Welcome to the Nurse Muse channel. This is Dr. Catherine Prado-Lefkowitz speaking, and today we're going to talk about amiodarone. And before we move on, make sure to check out www.nursemuse.com and sign up because it's a great tool to help you write care plans, and it has a ton of other great nursing resources on it. So make sure to check that out. And we're going to talk about amiodarone today and why it is important to know. So what is amiodarone? So the first thing you need to know is that it is a class 3 antiarrhythmic. It's a class 3 antiarrhythmic, and it's used to treat certain types of possibly fatal irregular heartbeats. And this is used to treat ventricular fib and ventricular tachycardia. So we use this medication. It's a class 3 antiarrhythmic to restore the normal heart rhythm and to maintain a regular, steady heartbeat. So what is a class 3 antiarrhythmic? Class 3 antiarrhythmics are drugs that block potassium in the heart. And the main mechanism is that it blocks the cardiac potassium channels to prolong repolarization. So when we have VTach or VFib going on, our poor ventricles are they're contracting at rates that they're not supposed to be contracting at. They're going out of control. So our goal is to stabilize the contraction, make sure that the heart follows the normal contraction pattern. So we want to kind of give the heart a break so that we can get the heart beating in its normal regular contraction pattern. So the way to do this is we're going to block potassium from going in the heart to keep it contracting at a fast pace and allow it to kind of relax in between contractions. So again, amiodarone, class 3 antiarrhythmic, used to treat ventricular tach and ventricular fibrillation. So how does the heart work? So the heart beats because of electrochemical signals called action potentials. And these action potentials travel and spread throughout the heart, and they zap that heart muscle into beating. And in between each zap, there's a break. And that break is called the refractory period. So during the refractory period, an action potential cannot zap the heart muscle into beating. When we have VTach or VFib, we have too many action potentials going to the heart. The heart is beating at times it's not supposed to be beating. It's not taking a break. So we need to somehow stop those action potentials from zapping that heart muscle into beating. So this is how amiodarone actually works. It prolongs the duration of the action potential and the refractory period. So it kind of stops that zapping, zapping, zapping. It extends the duration of the refractory period so that the electrical system of the heart can regulate itself and not be zapping, zapping, zapping. You can zap, relax, and then zap and relax. So once we get the heart rate under control, the result should be a lower heart rate. And then the second way that amiodarone works is that it blocks receptors called beta blockers. We know about beta blockers and beta receptors. So it blocks receptors called beta receptors, the beta receptors. So when we know that when the beta receptors are stimulated, such as with epinephrine, our heart beats really, really fast. And so when amiodarone lands on the beta receptors, it tries to prohibit epinephrine from stimulating the heart. So our goal is to slow down the heart rate. Now, there are some side effects of amiodarone that you need to know about. There are 3 really big ones that you need to know about. The first one is pulmonary toxicity. And one sign you might see with your patient is that he or she develops a cough. So they'll be coughing, coughing, coughing. They'll have shortness of breath. They might have some crackles and rails going on in their lungs. If we don't fix this, they could end up being hypoxic, and then respiratory failure can be life-threatening. The second side effect could be a QT prolongation, and this is because the cardiac cells rest longer, and so this is shown in our QT interval. So our patients need to be on cardiac monitoring to make sure that we don't have too much of a QT prolongation. And then hypothyroidism. So amiodarone has a high iodine content, and so this can affect the thyroid to lower its own hormone production. So we could send our patient into hypothyroidism. And then it can be hepatotoxic. So we need to be checking those liver function tests. So usually in the hospital, you'll see maybe signs around, it says check your PFTs, LFTs, and TFTs with amiodarone. So we want to look at our liver function tests, our thyroid function tests, and then we also want to be looking at our pulmonary function test as well. So what is ventricular tachycardia? It's also known as VTach, and it's a really fast heart rhythm that begins in our ventricles. So our SA and our AV nodes fail to generate an impulse. Remember that our heart has one main pacemaker and two backup pacemakers, and neither of them are working. The SA node is the first main pacemaker, and the AV node is the backup pacemaker, but they're doing their own thing in the heart. So our heart is not pumping adequately. We have no cardiac output. So on the EKG, our rate is going to be seen as very high, between 200 and 250. Our rhythm is going to be spaced. We're not going to have a P wave. We're not going to have a PR wave. And our QRS wave is going to be very wide and uneven. And there's a picture here on the right for you to see what VTach looks like on an EKG strip. So remember that VTach begins in the lower chambers in the ventricles and is very, very fast. When it lasts only a few seconds, it's okay. It's not going to cause a huge problem. But when this VTach is sustained, it can lower the blood pressure. It can result in our patients fainting or having lightheadedness. And VTach is a precursor to VFib, which we do not want our patients to go into. So remember amiodarone, class 3 antiarrhythmic. It works on the potassium in the heart, and it works on the ventricles. So we talked about this SA node in the last slide. So what is the SA node? Like I said, it's referred to as the pacemaker of the heart. So it coordinates the heart contraction. So when it stops working, the heart doesn't know what to do. It's located in the upper wall of the right atrium, and it generates nerve pulses that travel through the heart wall, causing both atria to contract. The SA node is regulated by the autonomic nerves of the peripheral nervous system, and the parasympathetic nervous system and the sympathetic nervous system send signals to the SA node to either accelerate the heart rate or to slow down the heart rate, depending on what the person is doing. So if you're exercising, the heart rate is going to increase because your body has increased oxygen demands. So a faster heart rate means that blood and oxygen are delivered to muscles at a more rapid rate. And when a person stops exercising, the heart is going to return to a level that is appropriate for normal activity. So what is the AV node? The AV node lies on the right side of the partition that divides the atria near the bottom of the right atrium. So when the impulses are generated by the SA node, they reach the AV node and they are delayed for about 1/10 of a second. And this delay allows for the atria to contract, so they empty the blood into the ventricles before the ventricles contract. The AV node then sends the impulse down to the atrioventricular bundle to the ventricles, and the regulation of electrical signals by the AV node ensures that the electrical impulses do not move too rapidly, which can result in AFib. So I put a picture here for you to visualize where the SA and AV nodes are located in the heart. So what causes VTach? So something's not working with our ventricles. There's a dysfunctional contraction. So this can be due to stress. This can be due to stimulants such as taking methamphetamine. This can also be due to digoxin. Of course, we're always worried about our electrolytes, so there could be low magnesium or low potassium going on in the heart. And then, of course, we're talking about a weakness or injury to the cardiac muscle where it loses its function. So we're thinking about a heart attack or heart failure, or maybe an infection in the heart like myocarditis, or maybe heart valve diseases. So think about anything that can affect the heart, how it's going to function and pump that blood forward. So what are some signs and symptoms of VTAC? So you can remember the mnemonic collapsed, COLAPSED. So the first is going to be chest pain. We're not getting oxygen to our muscles, so we're going to have chest pain, some ischemia going on. Our oxygen saturation is low because we don't have any oxygen moving around the blood. We're going to be lethargic because we can't move without oxygen going to our muscles. We're going to have anxiety because we can't breathe fast enough to get our heart pumping fast enough to get the blood to the periphery. Our heart's going to have palpitations. We're going to have shortness of breath. Again, our heart is going to try to overcompensate for not pumping out enough blood. It's going to elevate its heart rate. And then all of this is going to cause dizziness. So what are some nursing interventions? So before this turns into VFib and cardiac arrest and death, our goal is to reset the normal electrical conduction in the heart. So the first thing is we're going to assess the patients for those signs and symptoms we just went over. We're going to feel for a pulse. If there is a pulse, we're going to give amiodarone, and we're going to do cardioversion about 50 to 200 joules. If there is no pulse, we're going to start CPR right away. We're going to do defibrillation. We're going to set it at 200 to 360 joules. We have to reset that SA node. We're going to give lidocaine to relax the ventricles, and we're going to give our amiodarone to stabilize the rhythm. And this should put us back into a normal rhythm. So what is VFib? Ventricular fibrillation is the cause of cardiac arrest. So if you think about your ventricles, your ventricle muscle is just twitching randomly. It's not contracting in a coordinated function. And so the ventricles fail to pump blood around the body. Because of this, it is classified as a cardiac arrest rhythm, and patients in VFib should be treated with CPR and prompt defibrillation. So left untreated, VFib is rapidly fatal as the vital organs of the body, including the heart, are starved of oxygen, and as a result, the patients in this rhythm will not be conscious and they will not respond to any stimuli. So causes of VFib, let's see, anything that can affect the heart's function, any trauma, any infection, any past myocardial ischemia. So heart disease, heart attack, diseases that change the structure of the heart by making the walls thicker or weaker. Any other arrhythmias, remember we said VTAC is a precursor to VFib. Any heart surgeries. We always are looking at our electrolytes, too much or too little potassium in the blood. Have they been shocked? Or have they had any trauma, such as being hit in the chest with a ball, a fast-moving object? And this happens, unfortunately, in sports like baseball and hockey. So what will the patient look like in VFib? Well, the body's not circulating any blood, so the patient will probably not be conscious. And the biggest sign of VFib is the loss of consciousness. So the next obvious sign of VFib is that the patient will not have a pulse. Before the patient goes into VFib, they'll most likely have some signs and symptoms of like a heart attack. They'll have chest pain, shortness of breath, and maybe numbness in the arms or the legs. So here's an EKG strip of VFib. So there aren't any P, Q, R, S, or T waves. It's just pure chaos, as you can see in this strip. This rhythm is probably the easiest to recognize. And the heart rate can be really, really fast, anywhere from like 150 to like 500 beats per minute. So in VTach, you need to check a pulse first, but in VFib, there is not going to be any pulse. So you jump on and you start CPR while sounding out for help. The most important thing we can do is to get the defibrillator on the patient and to deliver a shock. And the shock is what's going to get them out of the VFib rhythm. And chest compressions are what's going to help sustain the patient long enough until you can deliver that shock.